Let me share my slides with you. Perfect. So we have a really exciting and complex topic today. It's a diagnosis of early chronic pancreatitis. The reason this is the most challenging topic in pancreatology is because this particular entity, it is potentially reversible, not only morphologically, but functionally. But at the same time, diagnosing is extremely difficult with imaging. So over the next 20 minutes or so, we'll delve into what's available to us in terms of diagnosis, diagnostic criteria. So this is the outline of my talk. And as we know, chronic pancreatitis, it's a multifactorial, it's fibroinflammatory syndrome with a prevalence of about 42 to 73 per 100,000 adults in US. It's been reported that up to 1/3 of individuals who get an attack of acute pancreatitis over next 3 to 8 years will go on to develop chronic pancreatitis. Conversely, about 50% of the patients with chronic pancreatitis, they have a documented episode of acute pancreatitis. Now, this statement is also in line with the sentinel acute pancreatitis theory, which proposes this continuum progression of acute pancreatitis to chronic pancreatitis. And as we know, there's no curative treatment of chronic pancreatitis. So there are several risk factors that have been reported and proposed that lead to chronic pancreatitis. The top of the list is smoking and alcohol. When we say alcohol as the risk factor, it means significant alcohol consumption, which is about 5 drinks per day. Not everybody who drinks heavily develop chronic pancreatitis. And as shown, the prevalence is about 40 to 70% in heavy drinkers. The odds ratio for somebody who drinks alcohol and has an attack of pancreatitis, continues to drink alcohol, the odds ratio is about up to 2 for them to go on to progress to chronic pancreatitis. The next most important risk factor is smoking. I think this is often underlooked, and I think we also probably are not doing a good job in counseling patients about this particular risk factor. We emphasize more on smoking, whereas emphasize more on alcohol, whereas smoking is the one which has been shown to have a higher odds ratio. And somebody who gets acute pancreatitis, they continue to smoke, they have higher odds of progressing to chronic pancreatitis. And if somebody is both smoker and drinker, it is a double whammy, literally. The odds ratio go up to about 5 or so. The other risk factors largely are genetic. There are about 8 genetic mutations that have been reported, with PRSS1 being autosomal dominant. Apart from this, factors like IgG4 disease, pancreatic duct obstruction, hypertriglyceridemia, chronic kidney disease are also responsible for progression to chronic pancreatitis. So all of us, when we see patients with a diagnosis of chronic pancreatitis, they can have myriad of clinical presentation. Important to note, up to 6 to 24% of chronic pancreatitis patients can have no pain at all. But as we all know, abdominal pain is the most common presenting symptom of these patients, reported in up to 90% of these patients. The abdominal pain is usually seen within first decade of the diagnosis of chronic pancreatitis. After about 10 to 15 years or so, it's more of exocrine and endocrine insufficiency that are the presenting complaints. And patients who come in with abdominal pain, they can have different pattern. It could be intermittent episodic, or it could be constant. And usually it's the constant that is more common in presentation, accounting for about 60% of the patients who come in with pain. Other than that, we see complications like acute pancreatitis, and up to half patients can have acute recurrent pancreatitis. They can have exocrine pancreatic insufficiency. They can have low fat soluble vitamin levels, ADE. They can be underweight. They can have problems with osteopenia, osteoporosis, and fracture. And these bone problems are more common in patients who continue to drink and smoke. These patients can present with diabetes, cholestasis because of the stricture of the intrapancreatic portion of the bile duct and seen up to quarter. Splenic vein thrombosis leading to gastric varices, may be presenting with gastric bleed is also seen in up to 10 to 20%. Small intestinal bacterial overgrowth, pseudocysts, and other common complications. Opioid dependence is again a growing epidemic, especially because of this chronic pain syndrome seen in up to about 5% reported in studies. And group pancreatitis, which is largely from alcohol, can be seen in up to 1% of patients presenting with duodenal obstruction. The lifetime prevalence of pancreatic cancer patients in chronic pancreatitis is up to about 4 to 5. So, variety of clinical presentations. Now, moving on to definition, I think historically chronic pancreatitis was defined with a triad of steatorrhea, chronic calcifications in the pancreas as shown in this KUB, and diabetes. I mean, if you have patient presenting with KUB, it's a slam dunk. You have chronic pancreatitis. However, this is not always the case, especially in patients who may have early chronic pancreatitis. Now, why is definition and diagnostic criteria important? I think for several reasons. One, you can accurately diagnose the patient. Two, if you have the diagnosis, you can intervene, institute meaningful intervention, not only to halt the disease progression, but potentially reverse it, so that patient don't end up with complications or poor outcome. And finally, you can do high quality prospective studies if we have a clear definition of the disease entity. But as I mentioned, early chronic pancreatitis is a challenging entity, and it's not easy to come up with a consensus definition. And this is what the conclusion was from the international consensus meeting that happened in 2018. And this paper was published in 2019, where a group of 16 international working groups, pancreas societies, they got together to come up with the definition and diagnostic criteria for early chronic pancreatitis. So they came up with the 10 clinical questions as listed on this slide, with 10 corroborating clinical statements. As you see, the strong agreement was reached only in 5 out of these 10 clinical questions. There was no agreement as to the definition or the diagnostic criteria for early chronic pancreatitis. They, however, did agree that the term early implies to the disease state, not to the disease duration. They also agreed that early chronic pancreatitis is a stage of chronic pancreatitis with preserved pancreatic function and potentially reversible features. And other agreements were on the role of genetic and environmental factors, that they do play a role, but by themselves are neither necessary nor sufficient to make the diagnosis. And finally, they agreed that there are other disease entities that can mimic or can have similar features like early chronic pancreatitis. So even though no consensus was reached for the definition or diagnostic criteria for ECP, there are diagnostic criteria that exist from the Japanese Pancreas Society that were published in 2009 with a revision later on. So according to the Japanese Pancreas Society, ECP patients, they need to have 2 of the following clinical features: repeat abdominal pain, located in the upper abdomen, abnormal pancreas enzyme levels, either in the serum or in the urine, up to 2 to 3 times upper limit of normal, abnormal pancreas exocrine function, and continuous heavy alcohol consumption, which is defined by more than 80 grams of alcohol per day. Along with this, imaging findings, which were seen either on EUS or ERCP, with the EUS features listed here, they need to have at least 2 of the following 7. These are very commonly used criteria, also mentioned in Rosemont criteria, which I'll be talking about a little bit later. Or on ERCP, patients should have irregular dilation of more than 3 duct branches on pancreatogram. I should make a note, however, that ERCP is not used as a diagnostic test for chronic pancreatitis. We usually go on to use non-invasive imaging tests, CT, MRI, or if that is not helpful, move on to endoscopic ultrasound. We don't use ERCP because of the risks and complications associated with it. So these Japanese criteria, they were studied for how good they are in identifying subjects who are susceptible to progression from ECP to a definite chronic pancreatitis. In this multi-center prospective study where they had 83 patients, they followed those patients for 2 years, and they found that only 4.8% of these patients who had early chronic pancreatitis features after an attack of acute pancreatitis, they went on to develop definite chronic pancreatitis. And all these patients who developed chronic pancreatitis, they had alcohol-induced acute pancreatitis, and they were still actively drinking and smoking. None of the patients who were either idiopathic acute pancreatitis or who abstained from smoking and alcohol progressed to chronic pancreatitis. In fact, half of them, they were later on categorized as normal because ECP findings were not seen on imaging. So they showed that Japanese criteria, they can be used in predicting who are the likely subjects who can progress to chronic pancreatitis. There are some limitations which largely are related to alcohol use being one of the required criteria. And second, relying on imaging, which as we know carries low specificity in diagnosing early chronic pancreatitis. And plus there is lack of inter-observer agreement when we perform these tests like endoscopic ultrasound. So talking about imaging, this table shows the sensitivity and specificity of different imaging modalities that are routinely used for diagnosing chronic pancreatitis. As we know, most everybody start with CT scan. The CT and MRI, they do have comparable sensitivity and specificity. However, I should note that up to 7 to 10% of patients with definite chronic pancreatitis can have normal CT scan. Now this table, the data listed on this table is for definite chronic pancreatitis. It is not for early chronic pancreatitis. And as understandably so, obviously, EUS and ERCP, they do carry higher sensitivity and specificity in diagnosing patients with chronic pancreatitis. So if you have a patient where there is a clinical suspicion based on the clinical presentation mentioned earlier, you suspect chronic pancreatitis, CT is normal, you should proceed, if able to, and there are no contraindications, to secretin enhanced MRCP. Why? Because it shows subtle ductal changes, and it is more accurate than just traditional MRCP alone. On top of that, secretin enhanced MRCP can give you indirect exocrine pancreatic function assessment, because when we give secretin, the pancreatic secretions, they pool into the duodenum, and that gives an assessment of the exocrine pancreatic function. It's an indirect assessment. However, the downside of MRCP is there is lack of validated radiological scoring system on, and there's no uniform imaging definition of early chronic pancreatitis. There were criteria that were proposed by the consensus group in 2018, but they have not been validated. Another issue with secretin MRCP is that this is only limited to the tertiary center. This is not the technology that is widely available. So the role of secretin MRCP in diagnosing non-calcific chronic pancreatitis was studied by the Minnesota group. They had 57 histologically proven non-calcific chronic pancreatitis patients, and they looked at the secretin enhanced MRCP, and they called more than 2 features as an abnormal MRI with a fibrosis score of more than 2. And they found that the sensitivity of secretin MRCP in diagnosing non-calcific chronic pancreatitis was about 65%, with a higher specificity of 89. Again, alluding to the fact that mild or early chronic pancreatitis is a difficult diagnosis to make on imaging alone. So moving on to role of endoscopic ultrasound, which is often the next test that we do in somebody where if MRCP is normal, we are still suspecting chronic pancreatitis based on the clinical presentation. I think most of us, we have heard about the Rosemont criteria, which are used for diagnosing chronic pancreatitis based on the number of features, both parenchymal and ductal. We can diagnose either definitive chronic pancreatitis, probable chronic pancreatitis, or early or suggestive chronic pancreatitis. If on EUS, we see the patient has 1 to 2 features, that's considered normal. Anybody with 3 to 4, as listed in this last part of the table, they probably have early chronic pancreatitis. Again, the issues with EUS in chronic pancreatitis, especially early chronic pancreatitis, are multifold. One, the predictive value of each of these features listed is quite controversial. Two, as we all know, you can see these features in several other situations, and they may not be pathological. Patients, just older patients in their 70s, 80s, patients who are diabetic, those who are smokers, drinkers, obese, they can have some of these features, and they may not be necessarily pathologic chronic pancreatitis changes. And finally, again, the issue of inter-observer agreement. That's why even though EUS has higher sensitivity, the specificity is quite low in diagnosing early chronic pancreatitis. However, you can add these adjunct techniques while you're performing EUS, and they play as complementary role in diagnosing early pancreatitis. One of them is direct pancreatic function testing. So while you're doing EUS, again, you can give secretin to the patient, collect the duodenal secretions, usually at 15, 30, 45, 60 minutes after secretin administration. And a positive test is considered value less than 75 milliequivalents per liter. Studies have shown that direct pancreatic function testing largely act as a rule out for CP test. They have a very high negative predictive value, as shown in the study published in Red Journal by Phil Hart, with a negative predictive value of 97. Our own center, my colleague Tyler Stevens, showed that combining endoscopic ultrasound with pancreatic function testing, it increases the specificity, especially in patients where it's indeterminate with 2 to 4 features on EUS. However, there are some downside. It's expensive. There is no validation, again, inter-observer agreement issues, and it's largely restricted to the tertiary referral centers. Now, some of the newer techniques that I've come across is an elastography. Most of the EUS, when we perform EUS, is in a B mode. There are different modes you can use to help diagnose fibrosis, are SR mode or SH mode. As of now, I would consider this as a complementary technique based on all the data that's out there. Its potential role is in patients where you clinically suspect they have early chronic pancreatitis, they have negative Rosemont criteria, and you can use elastography. The downside is that the SR mode, the studies published using, especially the one that was published in UAG in 2020, of more than 50 patients or so, the SR mode is very operator dependent. And we really don't know what's the ideal elastography technique. And then I think the role of artificial intelligence in diagnosing early chronic pancreatitis has still not been defined. It's still in infancy, but something that we should be looking forward to in future. So some of the other tests that you guys may hear about, when we are dealing with chronic pancreatitis patients is what I would call as indirect pancreatic function testing. Most of these are stool tests, fecal elastase, chymotrypsin, or 72-hour fecal fat collection. And the last one listed here is a breath test. None of these tests are sensitive enough to diagnose early chronic pancreatitis. And all of them, they have advantages and disadvantages. For example, fecal elastase, it has extremely high sensitivity for patients who have moderately severe chronic pancreatitis. It is widely available. It's not affected if patient is on pancreatic enzyme replacement therapy. All you need is a single stool sample. It's cost effective, and patients, they don't have to modify their diet. Disadvantage, as I mentioned, poor sensitivity in detecting early chronic pancreatitis. And if patient has watery stool or diarrhea, or if they pee in the stool, you will have a false positive test. The chymotrypsin is another test that we see being done. Again, same advantages, but the disadvantage is apart from the one that I mentioned for fecal elastase, chymotrypsin does get affected if patient is on PERT. So if you are planning on checking this, make sure patient is not on PERT. 72-hour fecal collection, we used to order this. I don't know the last time I've seen this being done. It is considered gold standard for quantification of fecal fat, but as we all know, it's not easy to do. Poor patient compliance, highly cumbersome. It is effective if patient is on pancreatic enzyme replacement therapy. And again, poor sensitivity in detecting early chronic pancreatitis. The breath test has high sensitivity for diagnosing severe chronic pancreatitis. It has good correlation with the tests like fecal elastase and chymotrypsin, but is marred by the same disadvantages as other stool tests. So what else is out there? I think some of the exciting development that are happening and hopefully will happen more in future are the biomarkers. As we know that exosome, these are the nanovesicles that are involved in cell-to-cell communication and regulation of biological functions. MicroRNA, these are present inside the microsome. You know, exosomes are normally found in the normal state and in the disease state. Now, these microRNA, they may be responsible for some pathologic disease state, and a panel of 6 of these microRNA listed here can be used for diagnosis of early chronic pancreatitis. I would say this is something that is still evolving, but an exciting development in the field of early chronic pancreatitis diagnosis. So the future, I think the future we look forward towards is more data from a PROCEED study, which is a prospective observational cohort study funded by NIDDK. This study is there to estimate progression of early chronic pancreatitis to chronic pancreatitis. Apart from them, that there are numerous other future potential analyses that can come out from this study, like on biomarkers, genetics, mechanistic study, microbiome, on imaging, etc. So this is something that was approved and started in 2018. So we are eagerly awaiting data from this particular effort. So I would conclude, ladies and gentlemen, with that early chronic pancreatitis is extremely difficult diagnosis. There's currently no international consensus on the definition. There is no consensus on the diagnostic criteria. We do need newer approach validated criteria to account for individual risk factors, clinical features, biomarkers, and imaging in the patients that we suspect having early chronic pancreatitis. We need newer precise therapeutic modalities to stop and reverse early chronic pancreatitis, and the role of AI and other advanced imaging technology is not yet clearly defined. I think with that, I stop. Thank you so much again for your attention.
Thank you, Prabhleen. And I want to say thank you for agreeing to take on such a challenging topic to kind of kick off this series. I realize that we didn't really throw you a softball on this one, but I appreciate the wonderful summary. I just have a few questions, and of course, to the audience, feel free to put in your chat if you have a question. I can recognize you, but and I will just ask a couple clarifications then. So it seems like you've nicely summarized kind of the limitations and the challenges. I'm wondering, therefore, in your practice, in how you go about it, realizing there's no right answer here, there's no clear consensus. Do you use 3 to 4 features to tell a patient that they have early chronic pancreatitis? Do you use, you mentioned Rosemont, but I wasn't clear if you adapt it, or do you, when you say 3 to 4, you're still just leaning on the standard criteria?
So a great question, Walter. So again, this is where more of it's an art rather than science. I think you are looking at patient as a whole. You know, if you have somebody who is a smoker, drinker, they may or may not have pancreatitis, they have mildly elevated pancreatic enzymes, they have pancreatic type of a pain, and you see these features, you can follow either the Rosemont criteria or standard criteria, but you do see the abnormality, which shouldn't be there in a 30 or a 40-year-old pancreas, right? So, so it's looking at everything in totality. So yes, you know, you can either standard or Rosemont. I would say you're looking at the patient in totality. I think I'm sometimes a little bit radical approach that I have taken, because diagnosing chronic pancreatitis, it is a big deal. You know, you're giving the diagnosis to the patient, which is potentially for rest of their life. It may or may not be reversible. There may be taboo attached to it, and there are implications. So you really have to be sure, especially if you're dealing with a younger patient. So a little bit sometimes radical approach, especially if patient is insistent, or if you think that's going to change in terms of their lifestyle or behavior, they may stop drinking or smoking. I have done biopsy. Now, yes, agree. There's this whole debate about it could be patchy process. If your biopsy, how do you know that you're going to get fibrosis or chronic pancreatitis changes on biopsy and all that? But that's a little bit of a radical approach that I have taken sometimes in these patients.
And I appreciate the candor, because I think the context of there's no, as you point out, there's no right answer here. So it's always interesting to have this discussion, to hear what other colleagues are doing. And to the point, I also have been doing a lot more biopsies. So I wonder though, when you do decide to biopsy the pancreas in a non-cancer, non-mass setting, how do you decide where to biopsy?
So again, we are looking at the entire pancreas, Walter. Sometimes you see some of the changes which which are attributed to ventral enlarge in the head of the pancreas. Again, doing core biopsy in the head is, given that possibility, you would want to avoid. So most of the times it's either the genu, which is the easiest and possibly the least risky site to biopsy, and you get a nice big core. So genu is where it's a straight shot body. I haven't generally taken biopsy from the tail unless I see features of more focal chronic pancreatitis there.
And I would agree. Actually, that's my approach too. I do the genu. Someone has an abnormal pancreatic function test, like a secretin function test or an elastase, but they have a normal EUS. I know you've kind of alluded to, it's kind of, it's a totality issue, but in general, let's just say they, hypothetically, they smoke a little bit, they drink a little bit, they have a little bit of pain. It sounds like dyspepsia, could be pancreatic pain. They come to you because they have an abnormal elastase, but their EOS looks relatively normal, maybe one or two findings. In your artful practice, is that early chronic pancreatitis?
Yeah, I think this would be the patient where I may take biopsy. Again, there's this whole concept of minimal change chronic pancreatitis that's out there also. And we know the limitations of EUS. So I think, again, if I'm dealing with a youngish individual, we know that he is the phenotype, he or she is the phenotype, and the diagnosis can impact the management or the lifestyle. This is the one there where I would biopsy.
And one last question then is, I liked how you talked about going beyond B-mode imaging and talking a little bit about elastography, both its potential and its limitations. Do you have an opinion about contrast?
So, okay, a disclaimer, we don't do elastography and we don't do contrast enhanced EUS. We don't have the technological capability. So from the literature, and I don't claim to be an expert on this, I don't have done extensive review because we don't have the technology. What's out there, I would say, yes, I would still consider it as a complementary. I wouldn't say this is something that is adding to the specificity of EUS alone. Yeah.
No, and I appreciate that. You're right. It is not quite yet clinically there, but I believe it's on the horizon. So, and I think there are several centers who are studying this. And so, great. Well, thank you so very much, Prabhleen. Again, this is not an easy topic to